Okay, Decubitus ulcer. So this gets even more graphic and more interesting, but here's how we kind of apply what we are talking about with tissues to what's next, which is treating injuries. What does this say for bed sore? So yeah, so Decubitus ulcer is the technical term for a bed sore. There's prolonged pressure on the skin. When you do a prolonged pressure, basically that it pinches off or it prevents the capillaries from providing nutrients to the skin, right? And we know that we have to kind of keep that nutrient input coming in all the time. So if I am laying down in one position and I don't have any capillary input into somewhere where there's a bony prominence, I'm touching my face, but it's mostly going to be in your shoulder, your hip bone, sacral area, these more high pressure places with a lot of weight. But the point is that you don't have blood supply. As soon as you do this, the capillaries are no longer supplying blood to the most superficial part of the skin right here or in this area. The blood's being pushed all around where my finger's touching right now with pressure. So if this happens for a long time with a lot of weight, which is what we have when people are immobilized in bed or in a chair, for example, then the blood flow doesn't get to that place and that tissue begins to die. So we'll look at this in more slide form. So, all right, so here we go. If you were in the supine position, right, the back of the neck would be an area where the cervical spine, like C6, C7 tends to protrude out a little bit, and more so, right, the more we have forward head posture, the more that's going to protrude out while you're lying down. So that's a potential spot. Elbows, definitely. The thoracic area, again, it will depend on the curvature of your spine and the amount of soft tissue that you have. If you are very well developed on either side of the spine, your vertebrae won't even touch the bed because your soft tissue will hold you there. So again, this is also dependent. People who are not mobile, this can go either way, but if one is out of optimal health, they may become very, very thin, or they may become very, very overweight and obese. So it can go either way, but being thinner and having less adipose tissue between bony prominences and surface area is also going to affect this. So say I'm like 100 pounds overweight. Is that going to really matter at the heel? As far as weight goes, I mean, I'm going to have a heavier leg in general. And then this heel, when I'm again in the supine position, I'm going to start to really deoxygenate. I'm going to get an ischemic area here. Because there's so many bony prominences in the ankle, and when you're turning, you can actually still, even on this side here, there you can get a pressure ulcer on this side in the lateral position. Okay, so yeah, so that's indicated here with the medial and the lateral malleoli, another bony prominence. The knee, the trochanter, and then the ilium has a bony prominence on the side as well. Also, look, this is illustrating like the side of the head. Anywhere really that there's a bony prominence, this can happen. Clinically, what I've seen the most, and you all have had a lot of clinical experience in this class, is like the sacrum, the heel, and yeah, those, yeah, and the like the sacrum, the ischial tuberosity area for someone who's wheelchair bound also can be an issue. But tailbone, yeah, tailbone too. So if you're in a rounded spine position while seated, the tailbone will tend to have some pressure ulcers build up. So in the early stages, they might not look like much, right? But this is an ischemic area. So the had lack of blood supply. You can tell a little bit that the coloring has changed. The skin tissue around it has changed a little bit as well. When I've seen a stage 1, it would just, by a test, you would push in and see if you get capillary refill. So this should change color. If I push on it, it should blanch out, become white. And then when I remove it, it should look whiter. And then it should get pinker again. Okay, so I want to say like depending on the amount of pigment as well, so like the amount of melanin present, that might be even harder to detect on an ulcer. But that's how I would decide if this was a stage 1, an early ulcer, or if it was just like something going on with the skin not related to it. Other clues would be, right, the location of this. So if it's on a bony prominence and I'm seeing some soft tissue change or tissue change of the skin, I'm going to test it and see if I get capillary refill. So without capillary refill, right, we see that this tissue isn't getting what it needs, and here it starts to deteriorate away. You can see the tissue, the granulation tissue trying to heal under here. So even though this is something that is getting worse, it is also, the body itself is trying to keep it healing. So it's trying to heal, but it's still not, the pressure hasn't been relieved, and it's still getting worse. So it just gets deeper and deeper, and it is going to penetrate through so we have the epidermis, the dermal layer, and then the hypodermis. And so now we're really getting close to the hypodermis. And then here we've gone through hypodermis, and we're looking at some connective tissue here. So treating these early is really important. They're more painful. They're going to be painful. So at some point you don't have neural input causing the same amount of pain in the deepest area of it. You're going to lose nerve sensation, but all this around it, it's still going to be painful, and it's getting wider, right? So we really want to treat it as quickly as possible and prevent it. Prevention is key with decubitus ulcers, or bed sores as they're known. Okay, we have way too many cases. It's about patient education, so letting people know how to prevent them, letting caregivers know how to prevent them, and then our job in the hospitals, in the home, is moving people who can't move themselves, or if they can move themselves, checking on them to make sure that they are. So who can't change their position? Someone with a spinal cord injury, multiple sclerosis, people lose a lot of neural control and muscle tone as that advances. Bone disease, anything. There's so many different ones that can lead to immobility, but here's a few. Bone disease can cause brittle bones, and then you can't move yourself because you'll break your bones trying to move yourself. And what else do I want to say about at risk? And I'm going to say, just again, what I see is folks who are severely obese tend to not move, and then because of the weight and pain, if they have an injury somewhere and they can't move because of the pain, I see that they get ulcers more frequently. Okay, so we're going to take a pause there for this section.